Bismillahirrahmanirrahim. Let's start today with the today's quote. To keep the body in good health is a duty, otherwise we shall not be able to keep our mind strong and clear. Today we are going to discuss about the cytomegalovirus and I am giving this presentation under the kind supervision of Professor Dr. Sairaj. The learning outlines of today's presentation will be the case presentation of the cytomegalovirus epidemiological trial, level of prevention, congenital cytomegalovirus, diagnosis of cytomegalovirus, treatment, recent updates, and MCQs related to the cytomegalovirus. By the end of this presentation, participants would be able to describe the clinical features of cytomegalovirus, its epidemiological trial, prevention, treatment, and recent updates. No, the case presentation of cytomegalovirus. A patient presented with acute mononucleosis and colitis caused by primary cytomegalovirus infection. This was characterized by the presence of atypical lymphocytes and hepatomegaly, elevation of transaminase levels, serology positive, anti-cytomegalovirus IgM and CMV antigenemia. Additionally, CMV positive cells were histologically detected in colonic biopsy specimens. The patient's symptoms and clinical parameters improved by initiation of intravenous ganciclovir. It was concluded that even if patients with ulcerative colitis are not treated with steroids or immunosuppressants, significant attention should be paid to acute cytomegalovirus infections in context of severe or persistent colonic infection. Now, what is cytomegalovirus? Cytomegalovirus is a common herpes virus infection with a wide range of symptoms, from no symptoms to fever and fatigue, resembling infectious mononucleosis, to severe symptoms involving the eyes, brain, or other internal organs. Cytomegalovirus, also known as heterophile negative mononucleosis. No, cytomegalovirus belongs to the herpes virus. There are nine herpes virus. Herpes virus, simplex virus is one and two. Varicella zoster virus, Epstein-Barr virus, human cytomegalovirus. It is also called the human cytomegalovirus 5. Human herpes virus 6A and B, and human herpes virus 7, and human herpes virus 8. Smith in 1956 and Bro and co-workers in 1956 and Weller et al. In 1957 independently isolated human cytomegalovirus strains. In 1960, Weller and co-workers proposed the term cytomegalovirus and subsequently isolated cytomegalovirus from the urine of the patients with generalized disease. No, the problem statement is that in United States, nearly only 1 in 3 children are already infected with cytomegalovirus by the age of 5. Over half of adults have been infected with cytomegalovirus by the age of 40. Once cytomegalovirus is in patient's body, it stays there for their life and can reactivate at any time. A person can also be reinfected with a different strain of the virus. Most people with cytomegalovirus infection have no symptoms and are not aware that they have been infected. Cytomegalovirus has now become one of the most common opportunistic pathogens encountered in patients with immunocompromised status or from congenital or acquired causes such as AIDS or transplantation procedures. Now, the epidemiological triad of the cytomegalovirus first is the agent. It belongs to the herpes virus type 5. It is the largest in herpes virus. It is a double-stranded DNA enveloped virus. It is nucleocapsid with 105 nanometer in diameter and 162 capsomeres. The host factor is that cytomegalovirus infects people of all ages. Over half of the adults have been infected with cytomegalovirus by the age of 40. The source, it can be from saliva, urine, semen, blood, or the breast milk. Mode of transmission is that it can be transmitted by saliva, sexual contact, placenta transfer, breastfeeding, blood transfusion, solid organ transplantations, or hematopoietic stem cell transplantations. Its incubation ranges from 4 to 8 weeks. The clinical feature is that if the individual with normal immune system, cytomegalovirus infection is often asymptomatic and manifests as infectious mononucleosis-like syndrome, like fever, lymphadenopathy, and atypical lymphocytosis. However, in immunocompromised individuals, such as the patients with AIDS or transplant recipient, disease manifests with fever, bone marrow suppression, and tissue-invasive disease such as pneumonitis, hepatitis, colitis, nephritis, and retinitis. And in the fetus, cytomegalovirus infection may lead to cytomegalic inclusion disease, characterized by severe neurological abnormalities, intellectual disability, and hearing defects. The treatment is that in immunocompromised individuals, in immunocompetent individuals, infection is usually self-limited. Therefore, no treatment is usually required. However, in the patients with immunocompromised function, the treatment of choice is oral valganciclovir or intravenous ganciclovir. These are the antiviral drugs, or the intravenous foscarnet and cidofovir are less preferred agents. Case presentation of a neonatal cytomegalovirus. A 4-month-old a 4-month-old girl presented with complaints of vomiting, diarrhea, and body contractions. It was reported that the girl had been vomiting whatever she had eaten 3 to 4 times a day and having gotten diarrhea 2 to 3 times per day since the previous week. More for the last 3 days, he had experienced a few seconds of contractions in her arms 3 to 4 times a day. The patient parents were found to have first-degree consanguineous marriage, and the mother had a history of cesarean delivery. The patient had microcephaly with long eyelashes, an upturned nose, highly eye pallid, retrognathia, distinctive ear, and a short neck. She had medical deviation of the second finger, agency of the middle finger, and syndactyly of the fourth and fifth fingers of the right foot. Moreover, she had irregular foot lines. Bilateral chorioretinitis was determined that the ophthalmological examination. The patient had impaired neuromotor development and had no control of her head and neck. Hepatitis markers are it is B and C negative, and also the hepatitis while the hepatitis A virus is positive. Toxoplasmosis, Eastern barbavirus, herpes simplex virus 1 and 2, rubella, parvovirus B19, and HIV serology were all negative. Serum CMV IgM was positive, IgG was positive, and urine CMV DNA PSR was 3303 million copies per milliliter. The mother serum CMV IgM was negative and IgG was positive. Congenital infection. It is defined as the isolation of cytomegalovirus virus from the saliva or urine within 3 weeks of birth. The commonest congenital viral infection affects 0.3 to 1% of all live birth. The second most common cause of mental handicap after Down syndrome and is responsible for more cases of congenital damage than rubella. In cytomegalovirus infected neonates, only 10 to 15% of newborns are symptomatic at birth. Serious complications occur later in life. These are the features that can develop in the baby who is infected with cytomegalovirus. That is permanent visual impairment, epilepsy, liver, lung, or spleen issues, brain abnormalities, that is microcephaly or mental retardation, permanent hearing loss, premature birth leading to low birth weight baby, are the coordination disorders. Cytomegalovirus infection source, it can spread from breast milk in toddlers, it can spread through urine or saliva, and in adults, it can spread through the sexual contact. In neonates, there is a uterine infection, then there is a placental infection. There may be primary or recurrent infections leading to fetal transmission. In 0.22 to 2.2 cases, it causes asymptomatic infection in 90 to 95% of individuals, while 20 to 40% transmission, it can lead to symptomatic infections that can cause 5 to 10% of the symptomatic infections that can cause intrauterine growth retardation, retinitis, microcephaly, jaundice, hepatosplenomegaly, the permanent damage to the to the ears or the eyes, and can lead to death in 20% of individuals. Complications are retinitis, colitis, esophagitis, hepatitis, encephalitis, pneumonia, and deafness. Levels of prevention for cytomegalovirus are primary, secondary, and tertiary. Cytomegalovirus is preventable. but precautions should have to be taken, like the pregnant women who have already have young children or who work with strong children or with young children are at higher risk of catching cytomegalovirus. Avoid contact with saliva. Kiss kids under the age of 6 on the forehead instead of lips or cheek. Wash your hands after contact with bodily fluids of kids under the age of 6. Cytomegalovirus is found in home and daycare settings. 75% of toddlers have cytomegalovirus in the urine or saliva in studies at childcare settings. Don't share utensil drinks or toothbrushes with kids under the age of 6. Primary prevention is health promotion and specific protection. Health education, which is the main pillar, it to avoid the infection, you need to wash your hands frequently, avoid contact with tears and saliva when you kiss a child, avoid sharing food or drinking out of same glass as others. Be careful with disposable items, clean twice and countertops. Practice safe sex. Vaccine. There is no licensed vaccine available for cytomegalovirus. However, there is a candidate live attenuated vaccine known as Town strain, but there are concerns about administering a live vaccine which would become latent and reactivate. Prevention of cytomegalovirus disease in transplant recipients is a very complicated subject and varies from center to center. It may include the following measures. That is the screening and matching. Screening and matching the cytomegalovirus strains of the donor and the recipient. Use of cytomegalovirus negative blood for transfusion. Administration of cytomegalovirus immunoglobulin to seronegative recipient prior to transplant. Give antiviral agents prophylactically such as acyclovir and ganciclovir. Secondary prevention involves the early diagnosis and prompt treatment, which is cytomegalovirus can be transmitted through breastfeeding, so it is necessary to start antiviral therapy for mothers and breastfeeding should be discontinued. Diagnosis is quantitative cytomegalovirus DNA by PSR diagnosis and monitor response. Qualitative cytomegalovirus DNA tracking by PSR is extremely sensitive but cannot differentiate active or latent. Tissue culture, serum cytomegalovirus IgG and IgM antibodies. These are good for screening. Histopathology involves delayed diagnosis and inadequate specimen collection. Treat with full dose IV ganciclovir or oral well ganciclovir. Monitor cytomegalovirus viral load or antigenema once weekly while on therapy. Daily continue treatment until undetectable. May consider 1 to 3 month course of scanty prophylaxis after completion of the treatment. Invasive cytomegalovirus retinitis commonly requires surgical intervention, whether for repair or for retinal detachment or for intravitreal instillation of ganciclovir by injection. Ganciclovir-eluting implants are no longer used in the United States. Now, the cytomegalovirus retinitis and treatment. This is the article. After diagnosis, the first step in the treatment is to administer systemic medications either in the form of intravenous infusion or oral administration. The most common choice is oral, while ganciclovir, given its ease of use and excellent pharmacokinetic. There is recommended regimen given cytomegalovirus broad present, but both in eyes and other organs. Local regional ocular therapy is largely reserved for cases in which systemic therapy is contraindicated or not well tolerated. Cytomegalovirus infection in transplant recipients. Cytomegalovirus infection in multifaceted phenomena with variety of direct and indirect effects in organ transplant recipients. Cytomegalovirus can disseminate to various organs and can cause death. Symptoms in transplant patients include fever, arthralgias, pneumonia, gastric upset and ulcer, hepatitis, and multi-organ disease. Congenital cytomegalovirus infection. It is a common virus that infects people of all ages. Over half of the adults have been infected with cytomegalovirus by the age of 30. Most people infected with cytomegalovirus show no signs and symptoms. When a baby is born with cytomegalovirus infection, it is called congenital cytomegalovirus. About 1 out of every 200 babies born with congenital cytomegalovirus infection. About 1 in 5 babies with congenital CMV infection will have long term health problems. Cytomegalovirus is the most common infection cause of birth defects in the United States. About 1 out of 200 babies is born with congenital cytomegalovirus infection. 1 out of 5 babies with congenital CMV will have symptoms or long-term health problems. In most rare cases, CMV infection can cause uh, uh, pregnancy loss. Now the time for the recent updates regarding the cytomegalovirus infection. The first article whose title is Pre-Transplant Cancer Prophylaxis to Prevent Cytomegalovirus Infection. Sorry. The article is Pre-Transplant Cancer Prophylaxis to Prevent Cytomegalovirus Infections in Allogenic Hematopoietic Stem Cell Transplant Recipients. The aim of the study is that the study was done to determine the frequency of cytomegalovirus reactivation and symptomatic infections with pre-transplant prophylactic encephalopathy versus no prophylaxis in patients undergoing allogenic hematopoietic stem cell transplantation. This study assessed the incidence of low-class mortality and overall survival for the first 100 days post-transplant in patients undergoing allogenic hematopoietic stem cell transplantation and receiving pre-transplant prophylactic encephalopathy versus those who received no prophylaxis. A total of 106 patients who underwent allogenic hematopoietic stem cell transplant were included in the study for retrospective analysis between 2017 and 2021. Patients who received encephalopathy prophylaxis were placed in group A, while those who did not were placed in group B. Encephalopathy was administered at a dose of 5 milligram per kg twice daily, 7 days prior to transplant, and ceased on the day of transplant. Our patients were placed on acyclovir 400 mg twice daily from day 0 to day 10 of transplant. Patients received a weekly or bi-weekly test for quantitative serum cytomegalovirus PCR till day 100 post-transplant. CMV reactivation was defined as viremia of greater than 150 international units per milliliter. Data was analyzed using SPSS software 26 version. Ganciclovir prophylaxis was associated with the lower degree of cytomegalovirus reactivation, 38 with prophylaxis versus 44 without prophylaxis, but with a higher rate of transplant-related mortality, 14 with prophylaxis versus 4 without prophylaxis. The increased transplant-related mortality was likely due to primary engraftment failure in 7 with prophylaxis, while no cases of engraftment failure were seen without prophylaxis. The conclusion is that cytomegalovirus prophylaxis with tensiculoprid is effective in preventing cytomegalovirus reactivation at the cost of increased transplant-related mortality in the form of primary engraftment failure. The second article is that cytomegalovirus infection in pregnancy, prevention, presentation, management, and neonatal outcomes. The purpose of this article is to provide a brief overview of the epidemiology presentation, diagnosis and treatment, antenatal cytomegalovirus infection, and cytomegalovirus in neonate. Maternal cytomegalovirus infection in pregnancy often presents with mild cold-like symptoms or is asymptomatic. The virus can be vertically transmitted to a growing fetus, and the risk of transmission and severity of fetal impact varying by timing of experience in pregnancy. Most neonates born with cytomegalovirus show no signs at birth, yet 15 to 25% will have long-term adverse neurodevelopmental conditions. Misconception that cytomegalovirus cannot be prevented or that newborns born without the signs of disease will be unaffected are common. Evidence supporting antenatal education and around behavior change to lower a woman's risk of acquiring cytomegalovirus during pregnancy is mounting. Cytomegalovirus infection during pregnancy could be common with the maternal fetal medicine specialist. There is early evidence for the use of antiviral medication in reducing the risk of vertical transmission. Identification of cytomegalovirus during pregnancy may help ensure the neonate receive timely treatment after birth. Midwives can play an important role in providing antenatal education about cytomegalovirus risk reduction and in initiating a diagnostic evaluation where there is clinical suspicion of the cytomegalovirus infection. Now, time for the MCQs. The first MCQ is congenital cytomegalovirus is a second leading cause of neurodevelopmental delay after Down syndrome worldwide. In how many weeks isolation of cytomegalovirus from saliva and urine of infected newborn can be done? Whether 1, 2, 3, 4, or 6 weeks. Which is the correct option? It's C, within the 3 weeks. Second MCQ is cytomegalovirus infection is the second most common cause of maternal handicap after Down syndrome and is responsible for more cases of congenital damage than rubella. Which of the following statement is true? A option is babies with congenital cytomegalovirus usually have no symptoms at birth. Babies with no clinical evidence of disease at birth have no risk of hearing or neurological development. C option is two-thirds of the babies with congenital cytomegalovirus at birth having hearing or neurodevelopmental problem. Diagnosis of congenital cytomegalovirus is not possible and up to 6 months half-life due to maternal antibodies. Babies with congenital cytomegalovirus cannot survive after 6 months of age.
C.
Yes.
B.
It's C. Two-thirds of the babies with congenital cytomegalovirus at birth having hearing or neurodevelopmental problem. Third MCQ is in the United States, nearly 1 in 3 children are already infected with cytomegalovirus by age 5. Over half of the adults have been infected with cytomegalovirus by the age 40. What is the most likely treatment of congenital cytomegalovirus infection? Whether IV ganciclovir, oral ganciclovir, refer to audiologist, manage symptomatically, treatment is not needed.
A.
Yes, it's
A.
ganciclovir given by the intravenous route. Cytomegalovirus infection is a common herpes infection with a wide range of symptoms from no symptoms to fever and fatigue to severe symptoms involving the eyes, brain, or other internal organs. To confirm the diagnosis of cytomegalovirus, one should request which laboratory test. Paired serology for the mother and newborn in first week, IgG to cytomegalovirus in newborn, blood for cytomegalovirus DNA in the first 3 months of life, urine or saliva cytomegalovirus DNA in the first 3 weeks of life, tissue culture for early diagnosis.
C.
It's D, urine or saliva for DNA, cytomegalovirus DNA in the first 3 weeks of life. Fifth MCQ, which of the following does not establish diagnosis of congenital cytomegalovirus in neonates? Whether urine culture of cytomegalovirus, IgG, CMV antibodies in blood, internuclear inclusion bodies in hepatocyte, cytomegalovirus viral DNA in blood by PCR or the tissue culture.
B.
Yes, it's B. IgG, CMV antibodies in the blood but do not establish diagnosis. Sixth MCQ, the prevalence of congenital cytomegalovirus infection is increasing in developing countries because lack of evidence. Which symptoms of congenital cytomegalovirus is highly reported, whether jaundice, hepatosplenomegaly, chorioretinitis, microcephaly, or the anemia.
A.
Yes, it's jaundice. Seventh MCQ is which body secretions are most common in the mode of transmission of cytomegalovirus infection, whether saliva, semen, urine, blood, or breast milk.
A.
Yes, it says saliva. It can be spread by kissing the child lesser than the age of 6 months. Eighth MCQ is a male baby born at 39 weeks of gestation with petechial rash, low birth weight, hepatosplenomegaly, and microcephaly. This is thought that baby might be infected during pregnancy. Select the condition which likely causes clinical presentation, whether rubella, toxoplasmosis gondii, group B streptococcus infection, cytomegalovirus, or the Down syndrome.
D.
It's the cytomegalovirus infection. Ninth MCQ is organ transplantation is one of the complicated procedures. The risk of infection is highly reported in these patients. The most common viral infection after solid organ transplantation between 1 to 4 months of surgery is cytomegalovirus, herpes, rubella, human immunodeficiency virus, or the hepatitis C.
A.
Yes, it's cytomegalovirus that can spread after organ transplantation. Last MCQ is a 78-year-old man with end-stage renal disease, diabetes mellitus, and microscopic polyangiitis, for which he was taking glucocorticoids, presented clinically with complaints of fever, painful glossitis, and taste abnormalities that had persisted for 1 month. The most likely diagnosis is cytomegalovirus infection, herpes simplex infection, Beckett's disease, syphilitic cancer, or the herpes zoster.
A. Cytomegalo.
Yes, it's cytomegalovirus infection. This is the key of all the MCQ. Here is our YouTube channel where all the presentations of the PGS are uploaded. And thank you very much for today's presentation.
Thank you very much. A very nice presentation, Dr. Wes, where you have completely covered the cytomegalovirus and what are the different diagnostic screening tests, as well as the recent advances. And the MCQ part was especially very enlightening, and it is really something that must be revised for understanding it better. Thank you very much, everyone, for joining the class. See you in the department today. Allah Hafiz.
Allah Hafiz.
Yes, thank you, ma'am.